Welcome to Vein and Lymphatic University. My name is Lowell Kabnick, and today I have the great pleasure of great speakers and great discussants. I'm going directly to Ed Mackay, who's going to be talking about the subject at hand. Ed, please share your screen. For those who do not know what we're talking about today, it's perforators, when to, when not to, and how to. With us, we have Mark Whitley as well as Álvaro Orrego.
When to, when not to, and how to treat. I started off with the American Venous Form SVS guidelines. They have a pathological definition of vein that's over 3.5 millimeters and greater than 500 milliseconds reflux. And treatment should only be done after axial veins, and I guess that should say after refluxing axial veins are ablated and patient remains symptomatic. We have, in this country anyways, we have to also look at the insurance guidelines if you want to be paid by the insurance company to do this rather than maybe directly paid from the patient. And most of them are requiring, active venous ulcers, previous refluxing veins have to be treated, and or really more advanced disease than we typically than just your typical C2 C3 patient. And each one has their own little caveat. You have to make sure you read them here if you're here, but you don't have to in other countries, so that you're lucky there. Or if you don't take insurance, obviously you could do that. And some things like they don't like Blue Cross here of Florida has sclerotherapy of perforator veins is not a covered treatment. And then you have Cigna, United. I won't go through all these because it's not really applicable. Now, what I did do after I made my little talk, I went back and someone told me, hey, you can do AI. And so here's an AI talk. And I'm going to be sharing you slides, my AI talk, as well as my original talk. And then at the end, I give myself a grade. But AI is a little more thorough. I mean, they went into a lot of detail here about what an incompetent perforator vein is or what a perforator vein is. And they said most clinically significant are medial calf and ankle perforators. I don't necessarily agree with that, but in my practice anyways, it's not what I see as much. And I think most of you know the C classifications, and most of you know what a diagnostic workup, which I did not go into those details. But here's the indications, and this is largely based on the SVS, American Venous Forum recommendations: active venous ulcers or recurrent and persistent venous ulcers after successful saphenous ablation. This is interesting. They include alongside saphenous ablation. Most of the other ones have said you have to do the ablation first and then wait. And then they will go as far as C4B, but as far as your C2 or C3 patients, they have low evidence level for treatment, but their expert consensus was that it is, if they fail compression therapy and have hemodynamically significant reflux, you can treat. So when not to treat, well, then I would say, well, when it doesn't meet the guidelines, but it's more of a question mark. Or I also feel like physicians also sometimes need to use their judgment. If you just don't feel like that's going to benefit the particular patient, then you don't. Here's a patient who didn't get treatment from me that had a refluxing saphenous vein because she had this little bump right here. And you could see a little perforator vein there. And it was under 3.5 millimeters, but it did have significant reflux. And she had no real significant symptoms from it. She mostly called about discomfort. So I explained to her, it could be treated, but it wouldn't be at all put through your insurance, and is certainly not considered medically necessary. So she elected not to have treatment. If I tried to treat that, I would have to do it as a cosmetic treatment. So that was my talk about when not to treat, but then I forgot about all the other reasons not to treat, which are, I think, pretty obvious. If your perforator vein is only secondary to the saphenous vein, you probably want to treat that. And if you feel like there's no evidence that it'll be beneficial, or that if there's an acute DVT or bad arterial disease, these are things that need to be treated first. So I think most of y'all would have known that anyways, but those are definitely good reasons not to treat. The treatment algorithm that they described, I didn't come up with an algorithm. I said that if you do a duplex first, you would have found incompetent perforators. But then you'd have to determine if there's great or small saphenous incompetence. You'd treat that first, and then reassess in 6 to 12 weeks is what they say, and see if there's any treatment needed. And then you could consider incompetent perforator treatment. And then you would select a modality based on seat class, anatomy, and patient factors. Well, that's pretty good. But really, I think in the end, you're going to have to make your decisions based on whether you feel like the patient will benefit. If their vein is 3 millimeters and refluxing, you might still consider treating it. You just wouldn't want to bill insurance for it, or if they have any other reason to have it treated. I just was going to share a lot of pictures of people without incompetent saphenous veins, just incompetent perforators. And I feel like, well, these people all deserve treatment. In my opinion, this guy has some kind of skin changes down here that I think is related to this whole problem. And he didn't have any really saphenous incompetence. And so I would hope I could go direct to treatment without, getting in a lot of trouble. He had a very large perforator that was refluxing. I call these popliteal perforators. I know they're technically the vein of popliteal fossa, but I see a lot of these, and they're, in my practice, they seem to be very symptomatic, very bothersome to patients. And again, I would look at this and say, do I have to treat this little bit of refluxing saphenous vein over here before treating this? I would kind of hope not. I'd rather go straight to treating the perforator vein. When I treat these perforator veins, I will talk about treatment, but I do tend to throw the book at them. I mean, try and do everything I can, because I can tell you that my experiences, they do recur fairly frequently. Here's another gentleman with a large incompetent perforator and no refluxing saphenous vein of any kind. So again, I'm not sure why they have to emphasize treating a saphenous vein. I took this guy's picture. He's referred to me after he had previous treatment elsewhere, and you can see some of his veins have been successfully closed, or at least partially successfully closed. But he had prior treatment even before this. You can see scars on him. There's even a scar right there from a stripping many years ago. So he's had lots of previous treatment. So, and he had varithena previously, but we were going to treat this with a laser and phlebectomy because it was just having a hard time getting that vein. It was a 10 millimeter perforator. I don't have a picture of it. So the third part of this is how to treat, and these were the suggestions I came up with, and then we'll go over what AI suggested. But radio frequency ablation, obviously, can ultrasound guided sclerotherapy many times. My favorite is the laser. I feel like it's just the easiest. Sometimes I do just a ligation. I make a stab incision and pull up and get the vein out. And I don't know much about using the cyanoacrylate, but I know I've seen some presentations at conferences where people are using that to close perforators, and I'm sure it probably works okay. Oh, let me go back. This is in about 2001. This gentleman came in with this big varicosity off his calf, had a perforator. Back then, I said, all right, we'll just do a phlebectomy on him. He was actually, interestingly, an FBI agent that investigated Medicare fraud. Obviously, he wasn't on Medicare. He had Blue Cross, federal Blue Cross, so I didn't have any issues. But I always like having those FBI agents come in and then tell them how, onerous some of these requirements are. They laugh at me. But anyways, so I did an ambulatory phlebectomy on him, and it looks like a really nice result. I don't have his follow-up, but about 2 years out, he recurred with a little bulge here and like more of a matting or blushing, a lot of spider veins in the area. And that was about 2003. And by that point, I had started doing a fair amount of foam, and I just foamed that area. And he, I think, got a pretty good long-term result, because I don't think I saw him back a few times afterwards, but long-term, I have not seen him back. I have fooled around with the RF ablation. This is the Medtronic one. I have not done the vein close. I've been in a room while it was being done, but I'm not real big fans of any of their radio frequency ablation perforators. I know they work, and they're just, to me, they're a little harder and more tedious than the laser. So this is the laser. I have to apologize for this video. It's very grainy. This is from 2003, I believe. And oh, wait a minute. I may not show you. Oh, I better not. No, I did. No, her name is there. Let me stop that. But I didn't black out her name. But that was the ultrasound image of me getting access. Here are some images of me struggling to get access into that vein. And this one over here is where I actually did get some blood return finally. And the only point I was going to show to this, these veins sometimes are very short. And if you're using a micropuncture needle, my little tip might be is to put in the stiff end of the wire very gently, so you don't just perforate right through the vein. Because if you put in the floppy end, if it ties a little knot at the end, you may have a hard time removing the wire and kind of mess up the whole procedure. Let me see. And then this is just me taping.
And you have 2 minutes.
Oh, all right. We're going to be done here in a minute. But anyways, here's the laser. This is not a ligation of a perforator, but I thought it was an example. You can make a tiny stab incision and do a ligation, and that can be done very cosmetically fine as well, especially on people who are thinner and it is up. I don't have any experience with the glue, so I'm not going to talk about that. This is the AI version, and they pretty much talk about everything, except for they did add SEPs in here. I didn't bring up SEPs. I haven't heard of, I don't know of anybody really doing that, or the open Lytton procedure. And I have absolutely no experience with HIFU. Of course, Mark can talk about that if he wants to. And they went and basically said that all these are options. So the key takeaway, that was their key takeaway. This is my key takeaway. You also have to be careful not to do unnecessary vein procedures and bill it to insurance. If it's something that's cosmetic or you think the patient would benefit from it, but it's not meets any of those criteria, you might get in trouble, like this cardiology group out in Arizona. So we have to be real careful about that here, especially with Medicare patients. So in conclusion, you need to follow your guidelines. Oops, sorry. Try not to go to jail. Offer self-pay if necessary. If you feel like there's something that to get the result you want to get, but it's not meeting the guidelines, you better not bill it to insurance. And I do feel like the AI did a little better job than I did, maybe a lot better job. So AI better than EM.
I can tell you about AI. Some of the times it's not correct. So be careful with AI. I'm going to go directly to Mark Whitley and ask him before he gives us an opinion. You can stop sharing if you would.
Okay.
What the UK guidelines are in terms of perforators.
The
And
latest
then we're going
ones,
to go to yours.
Yeah, the latest ones, as far as I'm aware, are the nice CG-168. I don't think it's come out since then. That was in July 2013. And they basically said the jury was out. They didn't know. So they asked for more. So the guidelines were all about truncal vein ablation, foam sclerotherapy, and the indications for treating clinical, but they weren't on the specific veins. So pelvic veins and perforators, no set guidelines at the moment.
And then I know that you are pretty liberal with perforators. Do you want to comment on Ed's uh, guidelines and not
Yeah,
his,
I
but
mean,
what's
of
going on in
course,
the US and what's
of course,
different? And
of
then I
course.
will ask Alvaro the same question.
Thank you. I think it's very interesting, and why I love international meetings is because we're guided by different things. So I'm very fortunate in my clinic. We're not covered by the NHS, and we're also not covered by insurance. So we do what we think is best for the patient. So our indications are either cosmetic or medical, and we will treat any perforator where there is some pathology at the skin end of the perforator. So whether it be a varicose vein, a thread vein, lipodermatosclerosis, venous eczema. So in other words, some proof that it's actually causing a problem. I personally think that the outflow of 500 microseconds is ridiculous because that was invented for truncal vein reflux, and the pathophysiology is totally different. So why you would take an indication from one vein with one sort of reflux and try and fit it into another vein with a different sort of reflux is ridiculous, but is what one does. I've seen a paper that has recently said no, it should be reduced to 0.35 seconds, but the trouble with even doing that, of course, is that you still then have to say, well, how much effort are you putting in to get the reflux? How much is the squeeze? So, and where is the perforator? So, I don't think the timing is very useful at the moment. I prefer to go on clinical pathology or ultrasound pathology. And as far as diameter is concerned, I think it was Klavinsky gave a very good talk where he said even if you use 3 centimeters, you're probably missing 30% of perforators that have some pathology outside. So I don't think either of those two criteria, I understand you have to follow them if that's what your insurance company says, but I don't think either has really got a scientific background.
Mark, do you do any hemodynamic testing on perforators looking at systolic and diastolic flows?
Very interesting. I've just published on the preprint server, College of Pathology preprint server, and we're trying to get published at the moment. I've been presenting around the world some infrared hemodynamics showing that if you lie the patient flat and if you get them to pump their leg, you can actually see the active or systolic reflux, whichever you want to call it, showing it does reflux in a different way than passive reflux. And so this whole area, I don't think we can come up with firm diagnosis at the moment. We can just turn around and say this is our opinion at the moment, but it's all a work in progress for perforators.
So the Paranum maneuver, et cetera, et cetera. But yeah, I'm glad we're looking at hemodynamics as opposed to
Oh,
Frank. Um, your treatment of choice, I'm sure, varies between perforators, but I'm going to ask this one question to you. If you have a C6 patient and you know that the patient has ilial femoral outflow obstruction, and also has superficial venous reflux, great saphenous, and has a incompetent or pathological perforator near the ulcer, what do you treat first?
Is that to me?
Yes.
Oh, sorry. So I would first of all do an air plethysmography, single cuff like the Latimer Kaladiki test, and I would see whether the how severe the is. Don't trust cross-sectional imaging, or IVUS. I would look at an actual function. If it was severe, then I would always do the stent first, or send them for stent first, and then look at reflux afterwards. If that showed that there was actually not much outflow obstruction, it was all just what appeared on an image rather than actually having significant, then I would probably do the passive reflux and the active reflux together.
And what about the
yes.
perforator?
Oh, that's the active reflux. Sorry, that's what I meant. So,
So, so
just hmm?
you would do the superficial and the perforator together.
I always do them together. Yes.
And
Yeah.
knowing
Okay.
that,
I agree.
and knowing that sometimes the perforators will disappear because of the great saphenous, but we won't go into the dynamics there. When do
They
you
Mm.
use,
They usually
Lowell,
don't if you look a year later. There's usually an acute, it looks as if they've disappeared, but you go back a year later, I think 81% have come back.
81 and not 80.
Not according to the paper, that was
Let me go to Álvaro for comments.
Well,
Not particularly what we're talking about, but your comments to Ed.
well, I have some questions. Well, I have a first one. To define reflux in perforator vein, do you consider for the panel, no, the systole or diastole of the cuff of a muscle pump, or do you prefer to use the distal compression maneuvers? Because it is very important to define very well the reflux and the importance of the reflux, no, the meaning of the reflux in the hemodynamics, no. I think it is very important to define when.
Are you
When
answering your own question? Are you asking the question?
It is a question for the panel, no?
Well, I will answer. I do not do those maneuvers. I've tried to point out at many conferences that the systolic velocity has been shown in many duplexes for axial reflux to have more of a indication of severity of disease, but I always get shot down. So I just stick with just the guidelines.
So it's amazing. Hold on,
we
Álvaro.
usually,
Álvaro, hold on. It's amazing that depending upon what country you're in, depends upon what people talk about hemodynamics and what the hemodynamics are. And that's why perforators are to me, a challenge. They're easy to say, oh, you've got a perforator, it's pathological, do it. I mean, that makes sense based on the criteria here, and there's a fair amount of literature to support it. But when you start getting into the trivial perforators, I think that's where we have a question. So I'm going to move on a little bit to the idea of treating underneath the perforator and the venous ulcer bed. And the question is, when do you do it? And we have Professor Bashira on as a guest who just wrote the seminal paper on that. But what do you think about treating it and when to treat? So
always,
Álvaro, when?
always,
When?
always,
When?
always, always,
Cuando?
because
Cuando?
when in our immediately, no, well, maybe a couple of weeks after, but it is absolutely necessary because when you study the reticular bed, always you have beneath an leg ulcer, you always find a dilated and a reticular bed and reflux. And well, we have a very good experience using high frequency transducers, you know. And now we're using 26 transducers, and it is a different word, because sometimes you can close the perforator vein, the axial reflux, but the patient continues with inflammation and some eczema. But when you treat the reticular bed, it stops.
Mark?
Yeah, so the dermal subdermal plexus, or the suborsal plexus, whichever you want to call it, the work from Ronald Bush showing the TRIS method of foam sclerotherapy, it gets good results initially, recurs, of course, if you don't treat the reflux. If you treat the reflux, as in the EVRA study, you can actually show that you can get the ulcer healing, but it comes back. The Swedish study showed, or Finnish, I can't remember, but it showed you really need to do both. And so, I think you need to do the truncals, the perforators, and then you need to foam the plexus. You get the whole lot, and that's going to give you
What about approaching the perforator and the subvenous ulcer plexus first?
Yeah, well, the interesting thing with that was the study that was done. I can't remember which Scandinavian country it was, but it's published, showed that it doesn't matter if you do the truncal veins first or the foam for the suborsal plexus first. It's your first intervention starts the healing. Now, they said that if you're going to be able to do the foam on the day, but you'd have to plan the laser, then it makes sensible to do the foam first because you start the healing process. But if you're going to close the perforators with planned surgery like laser, then it doesn't make a difference. Because so if you want to get the ulcer healed quickly, do the foam sclerotherapy when you see the patient, get it starting, and then put them in for their endovenous laser ablation or whatever ablation you're going to do, and trollop procedure or perforator procedure as a planned procedure. That way you'll get your ulcer healed quickest.
Ed?
Well, but
Hold on a
sorry,
second,
excuse me.
Álvaro, hold on a second. Ed,
Okay.
your philosophy?
Oh, I like the terminal interruption of reflex. What's that called? TERP. But anyways, the foam into the bed. It sometimes what I've done is do that first, only because I can do that quickly, cheaply while they're in there. They get their Uniboot on. Then I wait. I get the authorization. I may not get paid for that because I didn't get it authorized, but then I'll get the authorization for the ablation, and then I would do the ablation first. I think what I would probably do is wait till the ulcer heals, because I think that will heal it. But if there's still a real large incompetent perforator, then do the ablation through the ulcer. What was the ulcer bed, but I'm hoping it healed. I'm pretty sure it would be healed by that point.
We
And
have
I think it's just
4
nicer.
minutes left, and I'm going to, thank you, Ed. I'm going directly to the chat box. There's a question by AJ Khanna. Is it correct that in C5, C6 disease, venous ulcer, it is the length of the GSV more important than the type of treatment? And there was a recent paper by Kikuchi. Anybody want to comment on that?
I don't believe it, because I think you're talking about venous stasis and what the actual status of the tissue is under the ulcer, and I can't believe that the length of the GSV is more important than the diameter of it, the perforators, the size of the dermal subdermal plexus. So I think to try and put it down to just one single measurement is not going to be helpful.
There was a paper, as I said, it was published in JVS VNL in 2026. But anyway, read it and see what you think. Everything that we talk about is controversial. Alvaro, there's another question here. What about tortuous perforators? Of those, a tibial perforator, how do you treat those? Or do you even bother with them?
No, well, it not currently it is not a problem, because you can map the perforator, and if you need to puncture in 2 places in order to treat a tortuous vein, it is not a problem. It takes just 5-10 minutes. It is not necessary more. And no, sometimes if I need to treat a tortuous perforator vein, sometimes I puncture in two places.
Thank you. For me, in terms of treating a perforator, I'm not, I don't have a bias in terms of what you treat, as long as you know how to treat it and when to treat it. There is some talk about HIFU, which Mark has kindly volunteered very quickly because we don't have much time. There is talk about glue, and there's different types of glue out there. The faster acting glue in terms of settling seems to work very nicely, according to Professor Boskert. One quick moment, Mark, on HIFU for perforators.
HIFU is excellent for perforators because you don't have to cannulate it. It's an outpatient walk-in, walk-out procedure. And also you want to close the perforator at the point of fascial crossing. So all of that, excellent. The one thing about the HIFU is that because you have a focused ultrasound beam, you don't want to do the ones too close to the bone. That can be difficult. And working on ways to try and improve that at the moment.
It hurt. Anyway, thank you very much. We are going to wrap up this. Thank you, Ed, for talk, and Álvaro for joining, and Mark. Next week, we're going to talk about when is it okay to ablate a truncal leg vein with chronic iliofemoral outflow obstruction. The guest host will be Thomas Wakefield. I'll be on location. Dr. KJ Nagareth will be the speaker. Dr. Glenn Jakobowitz will be a discussant, as well as Dr. Windsor Ting. So thank you very much. I appreciate that. Anybody that would like to have a certificate of attendance, please put your name in the chat box. That would be helpful, as well as your email. So regards from VLU, and thank you, everybody, and have a great day.
Congratulations. Bye-bye.
Nice talk, Ed. Thanks.
Hey, thanks. See you, Mark.
Thank you for your time.